In this module, Pharmacology. This module gives you the working pharmacology needed to assess a suspected adverse reaction rather than simply record it. It covers absorption, distribution, metabolism, and excretion. Cytochrome, P450 interactions, pharmacogenomics, receptor pharmacology, and special populations. Learning outcomes. Explain the 4 stages of pharmacokinetics and describe how bioavailability, volume of distribution, and clearance shape drug exposure. Calculate time to steady state and washout from half-life and apply the result to reaction onset and D-challenge. Describe Phase 1 and Phase 2 metabolism and the roles of CYP3A4, CYP2D6, CYP2C9, CYP2C19, and CYP1A2. Distinguish enzyme inhibition from enzyme induction using documented drug, food, and herbal interaction examples. Why safety professionals need pharmacology. A case narrative that records what happened, but not why it could happen, gives the assessor nothing to work with. Causality assessment asks whether a pharmacological mechanism exists. Without one, temporal association is much weaker evidence. Half-life predicts whether a D-challenge or re-challenge result is meaningful or whether the timescale makes it uninterpretable. Interaction knowledge tells you when the suspect product is the trigger and when it is the co-medication. Pharmacokinetics, the ADME cycle. Pharmacokinetics is what the body does to the drug. Pharmacodynamics is what the drug does to the body. ADME stands for absorption, distribution, metabolism, and excretion, the 4 processes that together determine drug exposure. Absorption covers movement from the site of administration into the systemic circulation and is bypassed by intravenous dosing. Distribution is movement from blood into tissues, governed by lipid solubility, protein binding, and tissue perfusion. Bioavailability and first-pass metabolism. Bioavailability is the fraction of an administered dose reaching the systemic circulation unchanged, defined as 100% for intravenous dosing. An oral dose is absorbed into the portal vein and passes through the liver before reaching the rest of the body. First-pass metabolism is drug removal during that first passage through gut wall and liver and can be extensive. Drugs with high first-pass extraction show low and variable oral bioavailability, so small changes in metabolism produce large exposure changes. Volume of distribution and clearance. Volume of distribution is the theoretical volume needed to contain the total drug at the measured plasma concentration. It is an apparent volume, not an anatomical one. Values far exceeding body volume indicate extensive tissue binding. A large volume of distribution means little drug sits in plasma, which is why hemodialysis often fails to remove such drugs. Clearance is the volume of plasma cleared of drug per unit time and is the sum of renal, hepatic, and other routes. Half-life, steady state, washout, and D-challenge. After n half-lives, the fraction of drug remaining is 1/2 to the power n, so 5 half-lives leaves under 4%. Accumulation on repeat dosing reaches 50, 75, 87.5, 93.75, and 96.75% of steady state after 1 to 5 half-lives. Worked example 1. A drug with a 12-hour half-life reaches steady state and washes out in about 60 hours or 2.5 days. Worked example 2. Amiodarone has a UK-labelled plasma half-life of the order of 50 days, so 5 half-lives is 250 days, roughly 8 months. Phase 1 and Phase 2. Metabolism. Phase 1 is functionalization, oxidation, reduction, and hydrolysis, which add or expose a reactive chemical group on the molecule. Cytochrome. P450 enzymes carry out most clinically important Phase 1 oxidation, principally in the liver and the small intestine. Phase 2 is conjugation, attaching glucuronide, sulfate, acetyl, methyl, or glutathione groups to increase water solubility for excretion. Metabolism usually inactivates a drug, but not always. Prodrugs require metabolism to become active. Cytochrome P450, the 5 that matter. CYP3A4 handles the largest share of clinically used drugs and is present in both liver and intestinal wall. The U.S. Food and Drug Administration lists midazolam and triazolam as clinical index substrates of CYP3A. CYP2D6 is highly polymorphic and metabolizes many antidepressants, antipsychotics, and opioids, including codeine. CYP2C9 substrates include S-warfarin and tolbutamide. CYP2C19 substrates include omeprazole and lansoprazole. Enzyme inhibition. Documented examples. Inhibition is usually rapid because it depends on the inhibitor reaching the enzyme, so effects can appear within a day or two. The FDA defines a strong inhibitor as one increasing the area under the curve of a sensitive index substrate at least 5-fold. A moderate inhibitor increases that area under the curve at least 2-fold and less than 5-fold. Clarithromycin and itraconazole are listed strong CYP3A inhibitors. Honig and colleagues showed in 1993 that ketoconazole altered terfenadine pharmacokinetics with measurable electrocardiographic consequences. Enzyme induction. Documented examples. Induction increases enzyme production, so onset and offset are slow, typically taking days to weeks as protein levels change. The FDA defines a strong inducer as one decreasing the area under the curve of a sensitive substrate by at least 80%. Rifampicin, carbamazepine, and phenytoin are listed by the FDA as strong CYP3A inducers. Rifampicin also induces CYP2C19. Induction causes loss of efficacy rather than toxicity, and toxicity instead when the inducer is stopped and clearance falls back. Pharmacogenomics and metabolizer phenotypes. Genetic variation in metabolizing enzymes produces phenotypes usually described as poor, intermediate, normal, rapid, and ultra-rapid metabolizers. For an active drug, a poor metabolizer accumulates parent drug and is at higher risk of dose-related toxicity. For a prodrug, the logic reverses. A poor metabolizer gets little active drug and little effect, while an ultra-rapid metabolizer gets too much. Codeine is converted to morphine by CYP2D6. The MHRA restricted pediatric use after life-threatening events, including death in ultra-rapid metabolizers. Pharmacodynamics, receptors, and dose response. Pharmacodynamics covers what the drug does to the body, target binding, the effect produced, and the relationship of effect to concentration. Most drugs act on receptors, enzymes, ion channels, or transporters, and selectivity for that target is rarely absolute. An agonist binds the receptor and produces a response. A partial agonist produces a submaximal response even at full occupancy. An antagonist binds without producing a response and blocks the agonist. Competitive antagonism can be overcome by more agonist. Therapeutic index, on-target and off-target. The therapeutic index compares the dose or exposure producing toxicity with the dose or exposure producing the desired effect. A narrow therapeutic index means the toxic and therapeutic exposures are close, so small changes in clearance matter greatly. Narrow index drugs are the ones where interactions, renal decline, and genetic variation most often convert a normal dose into a reaction. On-target toxicity is the intended pharmacology occurring in the wrong place or to an excessive degree, and is usually predictable and dose-related. Special populations and a renal worked example. Neonates and infants have immature phase 1 and phase 2 enzymes and immature renal function, so clearance is reduced and variable. Older people commonly have reduced renal clearance, altered body composition, and polypharmacy, all of which raise exposure and interaction risk. In pregnancy, physiology changes, and the fetus is a second patient. MHRA reports valproate causes physical birth defects in about 10 in every 100 babies. MHRA reports neurodevelopmental disorders in approximately 30 to 40 in every 100 children exposed to valproate in utero. From mechanism to causality and signals. Rawlins-Thompson. Type A reactions are augmented pharmacology, dose-related, predictable from mechanism, common, and with relatively low mortality. Type B reactions are bizarre, not dose-related, not predictable from known pharmacology, rarer, and with higher mortality. Types C, D, E, and F cover chronic or continuing effects, delayed effects, end of use or withdrawal effects, and failure of therapy. Pharmacological plausibility is one component of causality assessment, alongside temporal relationship, de-challenge, re-challenge, and alternative explanations. That completes this module. The key takeaways and suggested further reading are summarized on the slide. The full references for this module are listed on the slide for your further reading.